Computer. Right. Hello, everybody. Welcome back to another episode of Move, Breathe, Live. I'm actually quite excited to talk today to my guest, who I will let introduce herself in just a few moments. But I just want to say, someone I've been following for a little while, and I think talks a lot about the same things that I do. So hopefully, if you've been interested in what I have been talking about, then this one will be a good one for you, especially around the breathing and oral health side of things. So, Brittny, can I pass over to you, please, to introduce yourself as who you are and what you do?
Yes, absolutely. I want to say thank you first for, having me on here. I'm super excited to be here. A little bit about myself. So my name is Brittny. I'm still getting used to saying Murphy because I just got married in early June.
Congratulations.
So I still kind of say Brittny Sciarra-Murphy. But I am a myofunctional therapist. My background is in dental hygiene. That is what got me interested into myofunctional therapy. I've been practicing myofunctional therapy for, since 2016. I'm also a Buteyko breathing educator. And I am also an educator for Dental Sleep Toolbox and Airway Health Solutions. So we teach other dental hygienists basically to become myofunctional therapists and to begin incorporating these practices into their daily clinics.
Amazing. Well, that's a lot in a short period of time. So let's start then, because I'd say the most used word there was myofunctional therapist. Now, I'm pretty certain I had no idea what it was when I first probably started following you. I think, again, I mentioned it before we started, but I think I started following you not long around the same time as I did a podcast with Sandra Khan, who wrote the book Jaws.
Yes, great book.
It was really great book. So and then she was talking about I've got that wrong.
No, there's a bunch of different names. So myofunctional therapy, orofacial myology, orofacial myofunctional therapy, they're all interchangeable.
Cool. So what is that then? Let's get to that, because I had to look it up because I had no idea what she was talking about. And so for people who have no idea, and especially maybe how it relates to dentistry, perhaps, and then from there we can go.
So the technical definition, it's the neuromuscular re-education of the oral and facial muscles. So we do a series of facial exercises and behavior modification techniques to promote optimal oral rest posture, which we'll talk about in a second, I'm sure. Breathing, sleeping, chewing, swallowing. A really great friend of mine and colleague, Carice, likens myofunctional therapy to personal training, which I really love. So personal training in the sense we work below the eyes, above the shoulders. And I love that analogy because our oral and facial muscles are the same they're the same muscles of the rest of our body. If we don't use them, we lose them, right? So you can't you can go see your personal trainer once a week, 3 times a week. But then if you leave there and you head to McDonald's, for a Big Mac, you're not going to create good habits. You're not going to create sustainable lifestyle changes. And it's the same thing with myofunctional therapy. Yes, we give you a series of exercises, but say those exercises take up, let's just call it 30 minutes out of your day, but they're probably not even going to take up 30 minutes. What do you do the other 23 and a half hours of the day? So it's creating that overall awareness of how you're posturing all these muscles.
I love it. That makes so much sense. And for me, outside of the breathwork sides of things, for me, I spend a lot of my time looking at movement and from the feet up. And, I've worked with under Gary Ward for a while, so it's all feet. And he always says the same. It's kind of like physios, PTs work from essentially the ankles up, and like then podiatrists work from the ankles down. And then there's no real thought about how they might potentially work together. And it's kind of, and it makes total sense actually, because I've spoken to Sandra and I've followed you and stuff. So I have an idea, and I wouldn't say I do 20 minutes a day, but I try to be much more aware of my functional or my facial postures. But let's get into this a little bit more then, because I think it's how, if we go from, let's say, children, because I'd say that's probably the place where the biggest opportunity for improvement would happen, would you say? I mean, I would assume by the time my facial structure has been fixed as an adult, there's less opportunity for change.
Yes, I mean, we do work with patients of all ages, but you have to think we can always optimize function, but we're only going to be able to optimize it to your current structure, right?
Yes.
So to that point, yes, but there are other avenues you can go down to help change that structure even as an adult. But yes, I mean, things are always easier in children as they're growing, but what a lot of people don't know, even by age 4, 60% of craniofacial development is done. And I see a lot of parents and they're always like, is it too early to start? And I'm like, no, we should have started a couple of years ago.
So do you find there's with that, because I've spoken to a few parents over the last few months and stuff talking about this, and they've been in touch with me, and I don't really deal with kids because I don't have kids and I'm not really into them, but and from my perspective, it's kind of the issue with children is getting them to do it. As an adult, at least you have the motivation to say,
yes,
I've got sleep apnea, whatever, I need to improve this. But as a child, ending up with mouth breathing, kind of, everything that goes with that. I guess that's maybe the harder, you want to start early, but then you've got that brick wall that you potentially run into.
Yeah. I mean, that's definitely, everybody always asks, who do you enjoy? What age population do you enjoy working better with? And I wouldn't say that I like working with, younger kids or, adults or what have you. But with adults, we can be much more in tune with what's going on. So the feedback I'm getting from my adults is awesome. So I do love working with adults. And with kids, compliance is an issue because myofunctional therapy is 98% patient compliance. I mean, I could be the best myofunctional therapist that ever existed. I'm not, but even if I was, it's still not up to me. I see these patients once a week, once every other week for 30 minutes, but what is it that they're doing all that other time? And like I said, they can be doing their exercises maybe, but then if, the child's a big gamer and they're constantly, slumped over, head forward, we're kind of on this perpetual wheel.
Absolutely. So let's just, with that, as you kind of talked about that then, and I've kind of briefly mentioned like breathing and slack jawed and whatever else, but why certainly kids, like I know some people will have heard me talking to Sandra or whoever else, and even Patrick from Boteco Clinic and stuff, but like, why is it for you that actual, coming from an oral dental point of view, then, with airway, because I've see, as I say, I've been following you and there's a lot about sleep hygiene and all these bits and pieces, but how is it that oral hygiene, facial posturing and hygiene, for want of a better word, affects facial structure? Because I guess that's a fairly reasonable place to maybe start.
Yeah, so we like to think that the tongue acts as a natural palate expander. So if the tongue is resting up in the roof of the mouth since birth, which it should, because we are born obligate nasal breathers. And if we are nasal breathing, that tongue should be resting up in that roof of the mouth. The tongue acts as like a scaffold. So if the tongue is up there, the upper jaw will learn to grow around it. If that tongue posture drops could be any reason, tongue tie, enlarged tonsils and adenoids, allergies, whatever is the cause of that posture being low, that upper jaw now has nothing to form around. So it becomes very constricted. That palate becomes very, very high and vaulted, can cause a deviation in the septum. And then you have to think, well, what does that mean for the lower jaw? In every dental occlusion, except for class 3, the lower jaw falls behind the upper jaw. So if you know that you have a narrow upper jaw, you're going to have a narrow or receded lower jaw, right? And then you want to think, well, then why do we care? What does that have to do with breathing? The upper jaw is also the floor of the nose. So they mirror each other. So if you have a very small upper jaw, you're going to have a small nasal cavity.
And then that's going to also, if your jaw is like receded because of the narrow, then you're also then going to be narrowing the airway behind as well.
Oh, yes, absolutely.
I guess then, especially when it comes to sleep, let's say, as we mentioned, like snoring and apnea and stuff is then going to be much more likely, I assume, if you've got a much narrower airway and the tongue's in the way and turbulent
absolutely.
air.
I mean, thinking about that space itself, yes, if we are pushing things back, we're literally impeding on the airway. And now if we're not having room, if your tongue is supposed to live in the top of your mouth, but there's literally not enough real estate for it, and then you go to lay down in bed, I mean, gravity is going to take over. That tongue is going to fall back into the airway and it's going to obstruct your airway. And
so from my perspective, as someone who is obsessed with how I breathe and I spend my life focusing on nothing but, and, I realize I'm not the norm for people, but, I still notice, and I I tape my mouth at night, but I still notice if I don't tape my mouth, I'm still at times noticing I'm snoring, or I'm noticing, there's a snore, or my mouth is falling open. I've got a dry mouth when I wake up, etc., etc. Now, when I've spoken to Sandra, and she's talked about how, the mouth is only one, oh God, what's the word? Valve or whatever, not valve, maybe the wrong word, but there's 7 different, did she say valve? I've forgotten the word now. 7 different things within the jaw structure that we need to be thinking about for like a better oral kind of health and facial health. So just taping the mouth isn't necessarily going to obviously then hold the jaw forward and hold the tongue up. From your perspective, obviously it does because it's what you do, but doing the exercises is the big part of that retraining, say, tongue to the roof of the mouth.
Yeah, and it's not just about the tongue. There's been research that shows that myofunctional therapy or oral pharyngeal exercises have been shown to reduce the AHI, which, we don't only want to worry about the AHI in a sleep study, but the AHI is how somebody is diagnosed with obstructive sleep apnea.
Yeah.
But it's been shown to reduce that AHI in 50% in adults and 62% in children. So, a lot of the exercises that we're doing, actually, this is really interesting. I was listening to another myofunctional therapy group, and one of the exercises that we do is we place a button in front of the teeth, we close our lips, it's like resistance, right? And then you pull the button out and you hear this popping sound. Well, this myofunctional therapist, her name is Samantha Weaver, went to Stanford University, and the ENT there wanted to study like what these exercises were doing on that pharyngeal wall. And so they, hooked up a camera to her, and they found that this exercise, which we learn as myofunctional therapists as a lip exercise to help increase, lip strength, was actually working that pharyngeal area. Wow. So, these exercises, yes, we are neuromuscular re-educating the muscles to rest in a certain area, but we're strengthening these muscles, we're toning these muscles. So, it's not shocking to, then see on the flip side that these patients are then being able to breathe better and sleep better, right? There's procedures out there that some dentists do it with a laser. It's called night laser, and they basically laser the tissues in the back of the throat to help constrict them. And that, coupled with myofunctional therapy with my patients, I've had incredible results with.
So, sorry, on that, I can't get my head around that. So they laser the back of the throat to what? Constrict the muscles to open the airway, to make the airway.
Tighten up the tissues.
Okay,
yeah.
Fine.
Yep.
Okay. Yep. And so what you were talking about with the button there, I could be completely wrong here because I can't quite picture what you mean, but are you going to do it for us and we can?
Yeah.
Cool. Perfect. I can share this. And again, when I spoke, so obviously when I spoke to Sandra, I'm going to probably bring her up because, it's how I got into this and whatever else. But the from her perspective of obviously there's traditional orthodontistry, which tends to then be like more cosmetic, it would seem, and drawing things, almost pulling retractive. And then she obviously practices more forwardontics, as she calls it, and like this idea of drawing things forward. And then she's got that, I've forgotten what it's called now, but the green thing that they put in the mouth, and then it kind of seems to teach them they have to, I don't know, get the tongue and everything in the right position, and then this little thing will pop out and it will like give you almost like a little feedback of where is the correct position.
I'm not sure if I'm familiar with that. I mean, maybe if I were to see a picture.
Yeah, I'm going to have a quick look now.
So many appliances out there now, and as a myofunctional therapist, we definitely have to familiarize ourselves with, wow, that was a tough one for me this morning. I haven't had any coffee. We have to know a lot of them because different providers believe in different.
This is
okay, yeah, it's kind of
called like a vacuum activator, I think she calls it, or they call it. So, so I think it like that fits in, and then I think something about the posture or the tension. So, there we go. Look.
So this is just a button that sits right in front of the teeth here.
Yeah.
You close your lips around it, and pop it out.
And so are you trying to restrict that, restrain it? You're almost trying to hold it in with your teeth.
Yeah, not your teeth, with your lips. And yes, you're playing tug of war. Like with the little kids, we tend to play, call it actually tug of war.
Cool, nice. And so then that's obviously then having a strengthening through the jaw, like through the facial muscles. But then, as you say, that because of those facial muscles are then getting worked better, it's actually then having an effect on the pharyngeal airway as well.
Yes, absolutely. And form follows function. So function is so important. And it's interesting because when I was practicing clinical hygiene, I remember, we always would get the orthodontist reports back. And once I took my myofunctional therapy course, and I'm like, I want to go back and I want to read some of these reports. And I would read them, and they would note that the patient had a tongue thrust, or the patient had incorrect oral rest posture, and basically say that the stability of results, is questionable due to this, but they never referred to anybody. They never referred to a myofunctional therapist. So, and myofunctional therapy is not new. It's been in the literature for over a century. So yeah, it's not as popular. It's getting more popular,
but do you think that's because, do you think that's because it's very much they have to do it themselves? Because that's what I find with my work, is I'm completely hands off in my movement therapy work. Like it's all, I'm essentially showing you what's inefficient and how you can move better, but then it's up to you. You've got to go home and do it. And so
I think that a lot of the orthodontists just think like, oh, the patients aren't going to go home and be practicing these exercises, but it's still, it's not adding stability to their results. So it's like, wouldn't you rather make that referral, let the patient understand what is going on? Like maybe if we explain to the patient how this is impacting them, and educate them. Like education is the foundation of everything. If you can explain something to someone very well, and like the light bulb goes off, like if you were to tell me or tell my parents, I mean, I didn't have braces growing up, but my brother did. And if you were to tell my parents that after investing $6,000 that my brother was probably going to relapse unless he fixed this tongue thrust, and the tongue thrust therapy, myofunctional therapy, was only going to cost another $1,500, I find most parents are going to go that route. I mean, you're making this huge investment, and to not fix the root cause, the underlying problem as to why they even need the orthodontics, it's mind-boggling.
Absolutely. I mean, and I think that's the clients I have who are the most successful are the ones who I think have managed to, for one, they tend to be the ones who have turned up to me because they've tried everything else. But like when I've explained and they've said, look, you have pain here because there's this and that, and we've got this injury and this and blah, blah, and they go, oh, no, why hasn't anyone ever told me that before? And I'm assuming it's probably similar with the jaw and the face. Like, so you mean I need to work on this, and then that's going to help with this, and yeah. And so, sorry, on that as well, in a minute, can you just explain what the tongue thrust is? Because I'm not totally sure I understand what a tongue thrust is.
Yes. So a tongue thrust, so you could have a low and forward tongue rest posture. Like when you're sitting here talking to me, that tongue could just be, down low. It could be in the floor of your mouth. It could be in the middle of your mouth. It might even be up a little bit, but forward against your teeth. But a tongue thrust swallowing pattern, when you swallow, that tongue is literally thrusting forward. Now it can thrust forward, which we would call that an anterior tongue thrust. It can also thrust like kind of in between your back teeth here. We would call that a posterior tongue thrust. Now it could be one-sided, it could be both sides. So there's different types of tongue thrusts, and that you might have also heard of like a reverse swallowing pattern or an infantile swallowing pattern, immature swallowing pattern.
Nice. And so again, well, I think it was in the book of Jaws, or maybe it was when I spoke to Sandra, and she was trying to explain to me like the idea of like a resting or like swallowing. And so she kind of talked about the position maybe of the teeth, and then how the bottom jaw, that you almost want the teeth coming forward and slightly touching, and being there, and then the tongue resting, and then you should be able to swallow with your tongue. And the first time I tried that, holy shit, that was like it felt so weird to have my tongue resting against the top of my mouth and to swallow. And if anyone's listening to this at the moment, just try it now. Like put your tongue in the roof of the mouth and try and swallow without your tongue move.
To be even more specific, for anybody that's listening, if you were to say the letter N, Nana, and if you're producing that sound correctly, where the tip of your tongue hits, that's where the tip of your tongue should be anchored. And then when you swallow, the rest of that tongue has to come up. I mean, generally speaking, and I don't know if you've already talked about oral rest posture, like what that is on your podcast before. So maybe we can kind of we should start with that.
That'd be great.
The whole tongue should be resting up in the roof of the mouth. Now that means the tip, the middle, and the back of the tongue. Now that's where if we have some kind of tongue tie or restriction, it's going to be hard to get that whole tongue resting up there. You could maybe have the tip of the tongue up there, but if that middle to back of the tongue is not up there, that is not good oral rest posture. And then when you swallow, the only thing different between your oral rest posture and when you swallow is your back teeth should come together. So I always quiz my patients. When is the only time that our back teeth should ever touch? And that is really when we're swallowing. The tip of the tongue is already up there. We swallow, that middle to back part of the tongue elevates up, seals, and then whatever we have in there, a bolus liquid, will be propelled down.
Well, I can feel that as well. Like then you when you say that, it's like really interesting to suddenly find that anchor in that end spot, for want of a better word.
And then a really good test to know if you're swallowing correctly, if you take a sip of water and you try to swallow with your lips open like you're smiling, if you are not able to do that, that most likely means that you are asking for help from these other perioral muscles. There should be no reason that we shouldn't be able to swallow with our lips back, because we should not be using our lips to help us swallow.
I kind of feel like I should go and try that on camera and just see how wet I get.
Let's do it.
Right, I'm gonna get a glass of water. Let's see what happens. Right, let's give this a go then. Let's see how wet I make my t-shirt trying to do this. But I don't think I can even smile with hang on, lips are open.
Yep, so you would take the sip.
All right. Oh yeah, I can do that. Yeah.
And what you should feel, that water should be trapped. When you take that sip of water, it should be trapped between your tongue and the roof of your mouth. There should not be water spilling over into your vestibules.
Yep, I can feel that. Yeah,
Woo!
that's correct. There we go, guys. I've got that one nailed. So you can try that one. It's on camera as well. You can see it. So okay, so that's basically the basics, let's say, of resting oral posture then, and maybe swallowing. With that, what you brought up then as issues with that, and I know this is something which seems to be an issue which goes around my friends who have kids, like tongue ties. It seems that sometimes it's just crack on, you don't need anything doing. Other times it's, you know, a major thing. And where do we sit with tongue ties? What's
I mean, it's all about function, right? Like it's really interesting because you can see some tongue ties where I could tell somebody that I see on the street what a tongue tie looks like, and they'll see a picture of it and they'd be like, wow, that person's tongue tied. Sometimes they're very easily detectable. Now, sometimes those type of ties, some patients don't have any functional issues. So if there's no functional issues going on, why are we going to intervene surgically? There's no need. What benefit are they going to get from it? Then there could be some ties that are more posterior that aren't as easily detectable with the eye, and they're being very functionally impacted. And so sometimes we don't even know till we start working. Say I do an evaluation with a patient and I see what I think can possibly be some posterior restriction. I would never right off the bat make any kind of recommendation, because sometimes through therapy, we can optimize the function enough where it's no longer an issue. Perfect. So basically, like I get the question from my students all the time, like, when do I know when the patient's ready for a tongue tie? You know, because you get to a point in your program where you can't go any further. And if you can't go any further, then that tongue tie is an issue. And tongue tie symptoms even vary. My nephew was tongue tied. My nephew had no issues breastfeeding at all whatsoever. I mean, he was so chubby, like so chubby. But then some babies, they lose weight so quickly, their failure to thrive because of their tongue tie. Some people have speech issues because of their tongue tie. Some don't. Some also learn to compensate. A lot of people learn to compensate with their ties, whether that's, postural, You know, if it is speech production, maybe they're just not producing the sound correctly, but you don't hear it.
Okay.
And I don't know, how do you want me to get into like common symptoms that we see with tongue tie?
Yeah, maybe that might be pretty interesting. So with the tongue ties, what you were saying there then, with the potential bits that with them, just before we do go into that, like, so when you said it might be that they have trouble breastfeeding, so is that due to the inability of the tongue to then come up to basically form like a seal around the breast as they're
Yes.
right?
So,
Okay.
it depends, right? If we're talking about lip tie or tongue tie, right?
Okay.
So the
Is lip
lip
tie
tie
more
could
the
impact,
frenulum?
yeah. So the lip, we have
Oh,
a kind
sorry.
of under our upper lip, lower lip, we have buccal ones as well. So cheek
Okay.
one. That could impact the ability for the upper lip to real phalange well.
Mhm.
So the upper lip needs to create that deep latch.
Okay.
And then the tongue tie. So think about, okay, so the mechanisms, right, of breastfeeding essentially. The nipple is drawn basically onto that baby's tongue, almost as far back as that junction between your heart and your soft palate. So like right
Oh,
now,
wow,
if you
okay.
took your tongue and drew it across the top of your mouth, like you can feel hard palate until you get to the squishy part, right? Your soft palate.
Goes
That
back that far.
tongue, yeah, that back of the
Wow.
tongue has to do this pumping motion to be able to get that milk out. Now, if the baby can't, because they can't elevate their tongue enough to do so, they're going to have issues breastfeeding. And sometimes what happens too is, you know, we'll have moms come in and we talk about birthing history and we say, you know, were they breast or bottle fed? And they'll say, oh, well, I had supply issues. And sometimes it's not, it's the baby's inefficiency to extract that milk that then makes that supply go down. Think about supply
Yeah,
and
yeah,
demand,
yeah, yeah,
right?
yeah.
So even sometimes hearing that on a patient's history, you know, trouble, not even so much trouble breastfeeding, that the mom's just milk supply was low. That would even, you know, tune me into thinking like, oh, okay, well, let's see what happens when we get to the, you know,
And I guess
tetheral
if
tissues evaluation.
by the time they've got to you, that's already kind of been and gone, and the child is almost certainly have finished breastfeeding, unless they're kind of going till they're 5 or 6 or 7. But by from your perspective, is that something which, if you were at that situation when you were around someone, I mean, is there anything that can be done that early with the child potentially, or is it, do you have to
Oh,
let?
yeah.
Yeah.
Like, could they have their tongue released, do you mean?
Yeah. Yeah.
Yeah, I mean, the best time to do it is infancy. The very, very best time to do it is infancy. And the best form of like myofunctional therapy is breastfeeding.
Yeah.
So yeah, I mean, it's that age group when the child gets, you know, 1, 2 years old. That's a really tough age because you have to think about compliancy, like behaviorally.
Mhm.
How's that child going to be able to sit in the chair? Is the child going to let the parent get into the mouth to do the stretches?
Yeah.
So infancy is when it should be done. And I wish, and there are some countries where this happens, like Brazil, where every single infant that's born has a tethered oral tissues evaluation. That does not happen
Wow, that's
here.
that's
And it's
crazy.
so sad.
That seems like it's just such a simple, like an obvious,
It's
simple
such a
thing to do.
simple thing.
I mean, you think potentially how many, I don't know, potential people with sleep apnea or issues further down the line due to maybe just a simple tongue tie, which is then affecting whole facial oral structure, which then goes into potentially, you know, cause heart disease, like stroke, you know,
Yes.
everything that comes secondary to
I was
poor
just
sleep.
at a conference, the AAPMD. So it's the American Academy of Physiological Medicine and Dentistry. So it's called
Mhm.
Collaboration Cure. So we're really trying to get the medical and dental community to
Oh, that's
combine
amazing.
forces. And I met this cardiologist who, on all of his patients, is taking tongue range of motion ratios. I was
Wow.
like, oh my gosh, I literally need to clone you. Like, that was the most amazing thing I heard. And that just makes me so excited. And he's on a mission to be able to share all that knowledge. I think his wife is a pediatric dentist. So he
Wow.
learned all of this from his wife. And he
You
said,
put 2 and 2 together.
yeah, the amount of patients that he sees that have sleep apnea. I mean, think about it. Of course, sleep apnea is
Oh,
going to cause damage and stress on the heart. It only makes sense.
I mean,
And
yeah.
every other, I don't know, there's a book called oh gosh, what's it called? Treat the cause, treat the symptom. It's by Dr. Stephen Lamberg. I cannot remember the name right now. I have it out in my waiting room. But basically each chapter goes through, a organ system,
Yeah.
whether it's, endocrinology, oncology, or I should say medical disciplines really. And he's linking the likelihood of sleep apnea in these patients. It's a really interesting book.
I mean, I find that's fascinating because I don't know. I probably haven't said. I'd normally say it on every episode, so I might as well say it again. But like, I'm a nurse as a background, so my background was like cardiology as a nurse, and then I've gone to accident and emergency, and so cardiology is still like well and truly, something I love. And one of the reasons I had to get out was I was just fed up with people coming in with coronary heart issues, and it was like essentially, let's take you into the cath lab, have a look at an angiogram. Oh, look, you've got some furring up. Here's 5 pills, off you go. Like nothing else. There was no, they can refer them to cardiology, cardiac rehab, but I mean, cardiac rehab was pretty terrible. Like, it was awful, really. And I that's why I got out of nursing to a certain degree in general, because I was constantly, but I'm back in nursing a little bit, and I watch every single person in accident emergency, the ER, and they're all, slack-jawed, like low-slung jaws, like receded jaw lines, all breathing far too fast, too heavy. And for me, I mean, these people who are coming in with coronary heart problems or with, lung conditions, I spend a lot of time working with COPD and asthma and the like, and there's nothing that the health service are doing. Do you know what I mean? I look at it and the feedback or the help they're getting is basically take inhalers, take steroids, take blood thinners and stuff like that.
My father-in-law had a massive stroke in March, and the hospital he was at put him in a research study for sleep apnea. Now, I had a feeling that he had sleep apnea for some time, but whatever. So we had this sleep test done. Of course, it came back sleep apnea because the correlation between stroke patients and sleep apnea is also very high.
Yeah.
And then he was in the hospital, I want to say for like 3 or 4 weeks. And then he moved to the rehab facility, and he's been in the rehab facility since the end of March, beginning of April. We're now in middle of September.
Yeah.
And he's still not being managed for his sleep apnea. Now, how is somebody supposed to recover from a stroke when they have lack of oxygen? How do you think he's getting optimal recovery?
Absolutely.
It is mind-boggling to me. And their answer to us is that, well, there's nothing we can do about it because he has to go to his, primary care physician, have the sleep study done. The sleep study that was for the research study didn't count. And I'm like, but he's stuck here. Like he can't go anywhere. So we're just gonna ignore it. Right. It's so irritating to me because he probably would be doing better in his recovery if this could just be managed. And it's something, again, so simple. I don't understand how we can't do that. I mean, I get it, insurance and medical and let's not even talk about that, but
I mean, we're on the other side of things because we obviously don't have the insurance and medical side of things as such, but there's a constant lack of continuity of care for the most part. But also, I mean, over here, looking slightly outside someone's wheelhouse is just not done. And I've got 2 or 3 GP friends who are just have got fed up and are doing something different. I'm kind of starting to work with a guy called Dr. Steve James, and he got famous on over here because he stood up to the Secretary of Health about COVID and whatnot, and just said he wasn't vaccinated because he didn't really think the science was there yet, and blah blah blah. And anyway, but he's one of these doctors. He's an intensive care doctor, but he's very much like breathing is like the foundation of so much. And so between he started a whole free program of like moving and breathing and bits and pieces to try to bring this stuff, sleep, breathing, to more people, to hopefully avoid them having to use the NHS, which is what we basically are trying to do.
Yeah, it's very frustrating at times, and then it's there's just not enough of people advocating for their
Yeah.
like, you have to advocate for yourself, like forget
Mhm.
about it, because nobody in the healthcare field's unfortunately going to advocate for you at this point.
No.
And my father-in-law, what he's been going through the last 6.5 months has just shown me so much in healthcare, and it's sad. Like it's
Yeah.
very, very sad.
I
And
mean,
I'm
it's just
always
not
telling my
healthcare though,
patients,
is it? That's the problem.
yeah.
It's just not
Oh
healthcare.
yeah.
It's just like sick care. It's
Yeah,
just,
literally, that's such a good term for it.
yeah, there's nothing about health that comes into it. And this is literally the thing. The reason I got fed up with nursing was just there's no health involved in it. And even though it's a national health service, there's no health. It's just how, and this comes from the slightly hippie-ish kind of, the side of things that we are, but like it does emergencies brilliantly, but like health, it just does terribly, and like chronic conditions. And, as we've kind of already started to state, just how something as simple as, and everyone, like not everyone, people like going to the gym. People like having wicked muscles and six-pack abs and, whatever else, but, throat to cheeks or something is just
Mhm.
an area in which no one would even consider that you would hate. Like, I mean, I'll be honest, hands up, until recently when I've been doing lots of work around the eyes and the kind of the muscles around the eyes, I definitely have not considered the muscles of the face at all in all of my stuff I do. I mean, I took me ages to start to learn them. So, I mean, you can probably say however many muscles there are in the face that we need to work on, but yeah, it's going to be
Yeah, I mean,
enough.
and simple things that you can do. I mean, I obviously always suggest having an evaluation by a trained provider, a myofunctional therapist, because myofunctional therapy is very individualized, right? Like not everybody's going to need every exercise. There's going to be different interventions or different limitations that people are going to have that's going to affect their treatment. But just becoming more mindful, setting a timer on your phone or picking a color, like let's say you pick the color blue, and every time you see the color blue, you're checking in on yourself. Where is my tongue? Is my tongue resting up in the roof of my mouth? Are my lips closed? How am I breathing? That repetition day in and day out alone can help to retrain that oral rest posture.
Yeah.
So like I said, just having that mindfulness, practicing. I don't know if you've talked about nasal hygiene on your episodes before, but
You can dive into it. Like, I think it's always
okay,
good
cool.
let's get, I mean, like I say, from everyone knows I do nothing but talk about like nasal breathing, nasal, whatever, but I'm more than happy to like constantly talk about it. And I think the more times
Yeah.
people hear it, like the better.
Yeah. And that's something that can easily be incorporated. And I have people that ask me all the time, like, well, why? And I'm like, well, you brush your teeth, right? Yeah. You take a shower, right? Yeah. Why wouldn't you clean your nose, right? Nasal hygiene. It's the same thing as personal hygiene and dental hygiene. It's preventative. It should be preventative. I don't have allergies. I don't breathe through my mouth, but I still practice daily nasal hygiene. It's simple. So I really like people say it clear, X clear. It has an X because it has xylitol in it. Xylitol is antimicrobial. I really like this nasal spray. And that's something, like I said, that you can begin incorporating today or tomorrow, using a nasal spray, twice a day. They have a kids version. There's no reason the entire family can't be doing, their nasal hygiene routine together. I'm also a huge fan of the Neti Stick, which is an aromatherapy inhaler. So it's lavender, mint, eucalyptus, and menthol. Those are all nasal decongestants. We do an exercise with this that includes humming, and I'm sure you know a lot about humming and the wonderful benefits of humming. I always tell my patients, I'm like, okay, we're gonna do this exercise. You're gonna think I'm a little crazy, but I promise I will explain why. And then
so explain it then. Let's just quickly go through it. Explain it.
So what we do for the exercise, is a nasal inhaler. So you would insert it up your nose. You're gonna block the other side. The sequence is you inhale, you hum, you swallow, and you exhale. And you would do 3 times on each nostril. When you exhale, you don't want to unplug this nose. If you have to take this out, you would take it out to exhale. So you inhale, swallow. Oh, I shouldn't have taken it out. And exhale. But I'm showing you guys, you get it.
Yeah,
So
yeah.
why do we do the
Yeah.
humming? So the humming is supposed to help increase nasal nitric oxide. Nasal nitric oxide, well, not nitric oxide is produced in our entire body, but nasal nitric oxide is produced in our paranasal sinuses. So we do not get that when we breathe through our mouth. Nasal nitric oxide is a vasodilator. It's antibacterial, anti-inflammatory, antiviral. So if we're talking about allergies, we're talking about patients that have enlarged tonsils and adenoids, and we know that those are serving as an obstruction to breathing. And now we know that when we breathe through our nose, this wonderful molecule is released that is anti-inflammatory. It only makes sense, right?
Yeah.
And I always explain when I explain, the benefits of nasal breathing versus mouth breathing to my kids, my kiddo patients, we talk about how when you breathe through your nose, you have a filter system, like the filter on a pool. It's going to filter out all that yucky stuff. When we breathe through our mouth, we don't have that. And again, you can educate a 4-year-old, and that's one of the biggest things about myofunctional therapy. And sometimes my pet peeve is myofunctional therapy is so much more than just exercises, because the exercises alone aren't going to correct anything. You have to educate your patients. Your patients have to understand why they're doing something. Because if they don't, there's definitely I think to everything, a mental piece to it. I want to know why somebody's telling me to hum. I'm not just going to hum because you told me to.
Exactly. And hopefully you want, if on that as well, you also want to educate people to keep asking why. Do you know what I mean?
Yes.
I was driving around the country yesterday with my best mate, and I was talking about this exact, but the problem with the health service, really going back to that, is there's no why. The doctors have stopped asking why, and so do you know what I mean? It's kind of like, you've had a heart attack, here's 5 pills, but it's but why? And then you can kind of go, well, perhaps sleep apnea is an issue. Cool, but why have I got sleep apnea? Okay, cool. Well, actually, you know what I mean? Then you can almost get back to these very basic points of my facial posture and the like.
And it's the same, we in dentistry, so I was a hygienist for how long? 5 years before I became a myofunctional therapist. And I can't tell you how many patients I recommended a night guard to. I mean, think about, there's so many patients out there, people out there that clench and grind their teeth a lot. And yes, a night guard, like a traditional night guard, is going to protect your teeth. Like you might not grind your teeth. But why are we clenching and grinding? We have to figure out why. And they're doing such great research now that's showing how it's a protective mechanism of your body. So think about when you clench and grind your teeth, you activate certain muscles that actually help to bring your lower jaw forward. Now, in dental sleep medicine, we make sleep apnea patients appliances that literally do just that. These appliances advance that lower jaw forward to open the airway. Your body's a beautiful thing. It wants to keep you alive. Exactly. So again, it makes sense. Now, I'm not saying that every single person in the universe that clenches or grinds their teeth, absolutely 1,000% has obstructive sleep apnea or some kind of sleep disordered breathing. I do think there's a very strong correlation. But in my opinion, if we have that piece of information, before we put anybody in a traditional night guard that can make their airway worse, it can make the problem worse, why not just send them for a sleep study? Get that clearance that it's not an issue. And then what you're doing is not going to have negative effects on the patient. It's something so simple. But on the flip side, making a night guard is also something very simple for a dentist to do that is going to increase their production.
Yeah.
And at the end of the day, it's sad, but that's
what it comes down to. Yeah, absolutely. Yeah, far too often.
I pissed off some dentists, that's for sure, telling their hygienist that they have to screen for airway before they, recommend a night guard for somebody.
But again, it's a bit of a sad thing when, again, the health isn't the priority. Do you know what I mean? I kind of feel, maybe I'm being naive, but, you kind of feel you go into medicine, whether dental medicine or whatever, but to help people, nursing, doctoring, whatever, but kind of to help people and to make, not just to, get them out of your way and whatever else as quickly as possible.
Yeah. And that is something that's really awesome about the people that are in this, airway field, whichever way they're coming at it, orthodontist, general dentist, speech therapist, this cardiologist that I met. there is just something in like the passion behind these people. They want to they take the time. They do a very thorough evaluation before they go recommending anything. Because look at the end of the day, like let's say we're talking about dentistry and somebody needs all this restorative work like crowns, implants, what have you. If you don't address the airway first, your work's going to fail. So why? That's not putting a good name behind you, right?
No.
Like, and that's the part that I just don't get. Or even with orthodontists, like, this is an issue. This patient's probably going to come back because their case is going to relapse. So just address it now.
So in orthodontistry, then what's whether there's a round figure or not, but people who have orthodontistry and then kind of end up, and most of the time, again, people end up having orthodontistry because of crooked, like both of my brothers had it. I never had it, but they were both big thumb suckers, and maybe we should bring up thumb sucking as well. Yeah. But like, my big brother Tim ended up having, he had the full headgear and everything. So he was obviously pulling his teeth back into his head, or his upper jaw. They were trying to pull that back in, I guess. But what is the level of relapsing? Like, is there a figure, roughly a percentage that kind of goes around?
I don't know, honestly, if there's like an actual percentage, like, like research percentage or something, but
it's definitely a thing.
Again, if we're saying that form follows function and if you don't correct that underlying dysfunction, we have patients that wear the retainers religiously and still relapse. Your teeth will move. Your muscles are always going to win. Always, 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 always. So I don't know that percentage, but I know that it's higher. And when I network with orthodontists, they're like, oh my God, this is great. Just tell me, like, who do we have to send to you? And I'm like, literally anybody that comes through an orthodontist office has muscle dysfunction. It's what got them there. That is what made, the arches narrow, made the teeth crowded. It was that underlying muscle dysfunction. And thumb sucking, that's a big one. So think about.
So let's get into thumb sucking then. I've got a question first, because when I spoke to Sandra and I brought up thumb sucking, partly because I think my wife's somewhere around. My wife still sucks a thumb, as everyone knows. But so when I asked Sandra, I said, is thumb sucking ever a good thing, type thing? Because it seems to be something which pretty much most, I apparently never suck my thumb, but a lot of kids will suck their thumb at some point. And she comes from an anthropological background as well, and she said, yes, there probably is something. So there's an evolutionary reason why, but we should have got it out of our system by age whatever she said it was. Like it was over a year ago. I can't remember, like 2 or 3 or something like that. And then if we haven't, again, there's the question: why not? And through my work with Gary and anatomy and motion and things, I've heard stories about how a thumb sucking, and because of the way you push up into the roof of the mouth, how moving that kind of sphenoid and whatever else around, how that then completely changed a back pain purely. And so it was almost what was it, back or knee pain. So they were sucking their thumb to try to move things to then affect how their knee pain felt, which is pretty crazy. But so yes, from your perspective on thumb sucking, as far as how much does a thumb suck affect facial posture? Is that a thing? Because that's what everyone said. That's what the orthodontists were when both my brothers had done.
So we look at 3 things: the frequency of it, the duration, and the intensity. Now, I think, relatively speaking, they say that habits up until age 3 are technically considered normal. I personally don't believe that, but if you look that up, I'm pretty sure that's what it would say. I know that a pacifier is recommended for the first 6 months of life to prevent SIDS. But also, if a baby doesn't want a pacifier, that's totally okay too. There is a self-soothing thing. That's why anybody does any kind of habit, whether they bite their nails, bite their hair, bite their lips, suck their cheek, whatever, it turns on the brain and it senses all those good feeling, neurotransmitters. So when I see somebody, sucking their thumb, I more think that there's a potential airway thing that's going on, because when you suck your thumb, bite your nails, whatever, your tongue's going to come out of your airway, and it also brings your lower jaw forward. That lower jaw will come forward. Now, we just talked about why the lower jaw coming forward is good, because it's going to help open the airway. Now, I think that oral habits definitely affect that craniofacial development, because remember, we talked about, we want that tongue being in the roof of the mouth from birth. Your tongue is what is going to, the forces of it laterally and anteriorly is going to help grow that upper jaw. Well, now your jaw only has your thumb to grow around. So it's not abnormal to then see that high vaulted palate when that thumb has been up there, because you don't suck your thumb with your thumb under your tongue. Your thumb sits on top of your tongue.
I just tried that. I don't know if you saw that. That's what I was sucking my thumb through. I was just trying to go, where does the tongue? Oh no, that's definitely beneath the thumb. Yeah.
Yeah. So it's, definitely going to cause some issues there with growth. It also can impact the way the teeth come in. So it's not abnormal to see like the teeth flaring. So the upper teeth flaring out from, that.
That's what my big brother definitely had. He was definitely kind of like really gap toothed and like, and yeah, he was a big thumb sucker. So yeah.
But I will say there was a dentist. His name's Dr. Antonio Ferrante. I think he's out of Italy. Who said that when you have the tongue resting in the correct position, so up in the roof of the mouth, that also helps to turn the brain on and will release, those neurotransmitters, dopamine, serotonin, norepinephrine, what have you. So what's interesting with our programs is as we start to re-educate these muscles and we start to correct that oral rest posture, that need to want to have to suck your thumb kind of reduces. And the other huge thing, and I don't know, there's a great book. It's called Atomic Habits, I think.
Yeah. It's James Clear one.
Yeah. You want to know, like, what triggers the habit? Is there an association with it? So like with some kids, it's not abnormal for there to be like either a blankie or like a little stuffed animal. And anytime that blankie or stuffed animal is in their arms, that thumb just like immediately goes in. So for part of our habit, because we do habit elimination program, that is like our first step. We always eliminate the habit first, do our myofunctional therapy.
And on that, very quickly, sorry, if anyone wants to see that, you've got quite a few photos and videos on your Instagram page, which I've obviously had a look through previous this and stuff, but they're 3 weeks, like for some of them 2 or 3 weeks, and the difference in the teeth and the jaws is already crazy.
It really is. And as long as the child or the adult wants to stop, that's the first thing. If they don't want to stop, it's going to be very, very hard to correct that habit. They have to want to stop. And then it's all about empowering that child and giving them, the tools to help them, but yeah, once we can get that thumb or finger or whatever out of there, like you saw, I know what picture you're talking about, that child's bite closed.
Yeah.
Teeth that were just stuck up there started to erupt down. It's pretty incredible. So
it's amazing.
Yeah. And there's, little appliances and things like that can be helpful, like, replace the negative habit with a positive one. So like there's something called a MyoMunchie. They're out of Australia. That we use sometimes with our habit elimination program. So to give them that like oral sensory feedback can be really helpful too at times.
Just as an off, because we've basically run through the hour, which is obscene. But my functional therapists then, are they all from a dentistry background? Are they all, or do they, can anyone go, like, because I'm just thinking, like, in case anyone has an interest in what you do and anything else like that.
So no, a lot of us are usually registered dental hygienists or speech language pathologists, but there's also some physical therapists, occupational therapists. I know a couple nurses. You have to have some kind of healthcare license to be able to take the course. And then there's different courses out there and stuff to take as well, different institutes.
So I mean, I could definitely keep talking to you for another couple of hours probably, but I know you've got to go in a minute, and the Queen's being buried on TV at the moment, so that's all going on. But first things first, we've got the final question, which hopefully you might be able to give us a little something that people can do. But obviously the last question is always, if you could offer anyone who's listening to this a little tidbit takeaway that they could put into their daily life, maybe only takes them, 3, 5, 10 minutes a day, that might help them move, breathe, to hopefully live a happy, healthier life. What could you potentially give them to have a little go at? And obviously there'll be a video of it, so they can always access the video if you need to be.
Yeah, I mean, I think first and foremost, we kind of already talked about it. Nasal hygiene started tomorrow. There's no reason you shouldn't. It doesn't have to even be the clear nasal spray I suggested. I mean, if you want to do a neti pot, I mean, whatever, but practice some kind of daily nasal hygiene. I think, which I know you talk a lot about movement, like we have to get up, we have to move around, we have to stretch, we have to exercise. We can't be slumped over all day long at our computers.
Yeah.
And have those check-ins for yourself about where your tongue rests, because where your tongue rests matters. Keep your lips closed, bring your tongue up to the magic spot up there, sit up nice and straight, and breathe through your nose. Check, like I said, put alarms on your phone that go off, every couple hours. And for adults especially, you can retrain your oral rest posture.
So with that then, can you just go over it one more time? The tongue resting posture. So people who maybe weren't paying attention or were driving, whatever, what is the correct, where are we looking for a much more optimal tongue resting posture?
Yep. So tip of the tongue is going to be up right behind the upper front teeth. So again, if you say the letter N,
N.
Tip of the tongue should be there. Rest of the tongue should be lightly suctioned up there. So I'm going to do it and then drop my jaw so you can see. So the whole tongue should be suctioned up there. Lips should be closed. You should be breathing through your nose. Your back teeth should be hovering over each other. That you don't want them in contact. The only time your teeth should ever touch is when you swallow, but you don't want them gaping open either. That can also cause some TMJ issues. So you want to have those teeth hovering right over each other. Check those 3 things, sit up nice and straight, pretend like somebody's pulling a string from the top of your head. Leave a sticky note on your computer. If you are somebody that sits at your computer, leave yourself a sticky note. Check your oral rest posture. Everybody can do it.
Yeah. And what just with that, I saw Brian McKenzie. I don't know if you follow Brian McKenzie from Shift Adapt and stuff, but he posted something the other day, and I'd never tried it, and I just how actually as soon as you get your tongue into that resting posture, and then you try and open your mouth and breathe, you just can't.
You can't breathe through your mouth if your tongue is up. Everybody try it right now. It's pretty amazing.
It blew my mind.
You can't.
You just immediately draw through your nose. And I guess that goes back to, as you said, as children, we are born nasal breathers, and the tongue is resting up there, and it just forces you to breathe through your nose.
Absolutely. Brilliant. 100% obligate nasal breathers.
Thank you so much, Brittny. It's been an absolute pleasure. And before we do finish, if you can just quickly let people know where they can find you if they want to know more about what you offer, or obviously a big chunk of my listenership is going to be in the UK, so whatever, but if you can just who you are, where people can find you and where people can maybe dig into these bits.
And you could always share this with anybody as well, but our Instagram page is CT_orofacial_myology. So CT orofacial myology. Our website is www.myctom.com. You can email me, hello@myctom.com. Anyway, we're on Facebook, CT Orofacial Myology, but our Instagram page is definitely our more popular page.
That's amazing.
Thank you so much for having me. This was so much fun.
Thanks for coming and talking to me and enlightening me about more things as far as breastfeeding and all sorts is concerned. So as always, just brilliant. Thank you so much.
Thank you.
Thank you.